Okay, we will have a next speaker, Dr. ANASUA Ganguly Kapoor. So I'd like to introduce her while she's setting up. Thank you. So ANASUA currently heads the Oculoplasty and Ocular Oncology Division at LV Prasad Eye Institute at Vijayawada. She has completed her basic education from West Bengal and done her fellowship at LV Prasad Eye Institute. Prior to that, she did a post-graduation at AIIMS. She basically has literally, I would say, grown the department and built it, sort of piece by piece and brick by brick at Vijayawada, and now is a force to reckon with and does a lot of work at LV Prasad, which is creating not just the patient, but also creating awareness for ocular oncology, especially retinoblastoma. And besides this, she loves teaching and is actively part of a lot of research, and also has a great passion for Indian classical dancing. Her talk will be The Baby's Eyes Bulging, the Hits and Misses in Pediatric Tumors. Thank you.
Thank you, Savari, for that kind introduction. So, and also for the opportunity to present here today. So the topic given to me by Savari is the baby's eyes bulging, the hits and misses in pediatric tumor. It is, there's some problem, can someone help? It is blanked out here. I think we need to remove one.
और टाइमर को 10 minutes करो, 9 नहीं. It will come. We had tried it ना, अभी try किया था ना उनका, हो जाएगा. टाइमर को 10 minutes कीजिए please. Thank you.
So in our everyday journey in the clinics, whether it's a hit or we miss the target while treating a patient, we definitely learn. So today, in the next 10 minutes, I will be sharing with you my experience, my learning experience in treating these 10 cases. So the first patient is the 16-year-old girl who was brought to our clinic with by her mother with the complaint of both eye prominence since 1 year. This was a plain and simple case of pseudoproptosis secondary to high myopia. So just a simple refraction and measurement of the axial length helps in all these cases. So the first learning pearl is beware of pseudoproptosis. Ipsilateral eyelid retraction or a small eye or a contralateral ptosis or a big eye may mimic pseudoproptosis. So before we start with the etiological diagnosis of proptosis, rule out pseudoproptosis in all cases. So this 12-year-old girl came to us with sudden popping out of the left eye, and this was coinciding with the attack of upper respiratory tract infection. So this was the CT scan showed these ill-defined multiple cystic masses, microcysts, macrocysts, and which was transcompartmental, that is involving both the intraconal and extraconal space with air fluid levels, which was typical of a venolymphatic malformation with bleed. So she did well with aspiration of the blood and bleomycin sclerotherapy. So whenever there's a sudden intraorbital hemorrhage in a child, think of venolymphatic malformation. This 3-year-old boy was brought to us with the complaint of left eye vision drop since 12 days. He was treated somewhere else with IV methylprednisolone with a diagnosis of atypical optic neuritis of the left eye. But what do we see here? We see that the child has periocular puffiness. There is subconjunctival hemorrhage both eyes. Left eye had optic disc edema. And this is the CT scan picture where you see both eye has homogeneous soft tissue density extending, which is molding around the globe in the anterior cuts and posteriorly extending up till the apex. And the left eye, it is compressing on the optic nerve, causing the disc edema. So this, we ordered for a peripheral blood smear, which had a clear picture of acute myeloid leukemia. So whenever you see rapid onset proptosis with bilateral soft tissue homogeneous lesion, rule out myeloid sarcoma, just ask for a peripheral blood smear. But the case is not always so simple. Like this particular child, 6-year-old male, you can see there's a supraonasal mass and a very rapid onset since the past 10 days. There is a homogeneous mass in the supraonasal quadrant. We again ordered for a peripheral blood smear, but this time it was normal. We went ahead and did an orbitotomy with mass excision. And you can see there are round blood cells with loosely arranged and which was myeloperoxidase positives, again suggesting that this was a case of acute myeloid leukemia. CD68 and 34 positivity indicating that these were the M4, M5 types of AML. So negative peripheral blood smear does not rule out myeloid sarcoma always. The child can have alloleukemic leukemia. Again, this 5-year-old male was diagnosed elsewhere as orbital cellulitis and started on IV antibiotics. So what we see here is the right eye has a orbital cellulitis like picture. The globe behind is not visible. But what is very apparent and shouldn't have been missed is the left eye leukocoria, which is there. So the referring ophthalmologist had done a CT scan orbit where you see both eye has intraocular tumor with calcification. But this is a red alert there that these patients with bilateral retinoblastoma are at very high risk of developing secondary tumors. So CT scan orbit is not the ideal investigation for them. An MRI orbit would have been better in this case. So this was a both eye retinoblastoma. The pseudo-orbital cellulitis like picture in the right eye was because of tumor necrosis. So we treated only IV antibiotics have no role. We treated with IV steroids. The swelling came down and then the child was treated as per the protocol of retinoblastoma. So orbital or ocular imaging is a mandate whenever the fundus is not visible. Just a B scan helps in these cases. So this is a very interesting case. A 2-year-old girl came to us with the left eye prominence since 3 weeks. So what do we see here? We see that the left eye has proptosis. There is periocular swelling, which is extending towards the temporal fossa. There is exposure keratopathy and severe chemosis. In the right eye, there is periocular ecchymosis, the typical raccoon eye appearance. So CT scan orbit showed a triradiate mass, a heterogeneous mass you can see here with an intraorbital component, a temporal fossa component, and also an intracranial extension. There were lytic lesions on the bone, in the frontal bone, maxillary bone here. So on systemic examination, you can see that there's a distended abdomen, bilateral pedal edema. We went ahead and did a USG abdomen, and there was a mass in the adrenal gland. So this was a case of metastatic adrenal neuroblastoma, so the Hutchinson syndrome, where there is skull bone metastasis from adrenal neuroblastoma. So the learning lesson here, periocular ecchymosis, proptosis, and bony facial swelling in a child, please rule out metastatic neuroblastoma. This 8-year-old boy came to us with prominence with vision loss since 1 week in the right eye. You can see a homogeneous mass there causing indentation of the globe. There was a right eye cherry red spot or CRO causing the decreased vision. So peripheral blood smear was again normal. We went ahead and excised the mass, and this is what we found. So you can see a mixed population of inflammatory cells along with copious eosinophils and lymphocytes, CD31 positive, a typical finding in angiolymphoid hyperplasia of orbit. So the child responded well to oral steroids. So ALH, before this, I have never, seeing this case, I have never read about this condition also. So ALH is a rare benign idiopathic vasoproliferative disorder. They respond very well to steroids. So this 3-year-old child was diagnosed at optic nerve glioma, given chemotherapy 6 cycles with EBRT. And then the child was referred to us as a non-responder. So what do we see here? There are these brownish macules on the trunk, typical cafe outlet spot, and a fusiform swelling of the optic nerve involving the optic nerve and extending to the chiasma. So this is a typical case of optic pathway glioma in a case of neurofibromatosis type 1. So what we need to understand here is post EBRT and post chemo. So this is an extensive optic pathogenic glioma. So the treatment done was correct, but the expectation that the tumor will shrink with EBRT and chemotherapy is incorrect. Majority of the patients, what we see is that the tumor is stabilized post EBRT and chemotherapy. So we need to look for progression. Progression is what guides us in treating these patients. And by progression, I mean clinical deterioration, vision and visual fields, and radiological progression. So that is what we need to see and accordingly treat these patients. So a 5-year-old with rapidly progressive left eye proptosis, you see a supranasal mass, homogeneous, well circumscribed. So this was a case of orbital rhabdomyosarcoma. So these cases we need to avoid incision biopsy and perform a complete, as much as possible, debulking, and followed by chemotherapy and radiation, plus minus radiation based on the histopathology report. So excision biopsy is what should be done in these cases. Moving on to my last case, a 3-year-old with right eye prominence since 1 month. What do we see here? So a superior orbital mass causing bone erosion. So a typical finding seen in Langerhans cell histiocytosis. So whenever you come across such a patient, a child, you can do a frozen section and inject intralesional steroids. So it was CD1A positive, confirmatory for Langerhans cell histiocytosis. So superior orbital mass with bone destruction in a child, think of LCH, confirm with frozen section and inject intralesional steroids. Systemic workup is a mandate to rule out multifocal involvement in all these cases. So in our journey in this hits and misses, to summarize what we learned: beware of pseudoproptosis, sudden intraorbital hemorrhage in a child, think of venolymphatic malformation and consider bleomycin sclerotherapy. Rapid onset proptosis with bilateral soft tissue homogeneous lesion, always rule out myeloid sarcoma by doing a simple peripheral blood smear. Negative peripheral blood smear does not always rule out myeloid sarcoma. Orbital imaging is a mandate whenever you can't see the fundus in your clinic. Periocular ecchymosis, proptosis, bony facial swelling in a child, suspect neuroblastoma strongly. ALHE is a rare benign idiopathic vasoproliferative disorder. The diagnosis is clenched by histopathology. They respond well to steroids. Combination of clinical deterioration with radiological progression guides treatment in optic nerve glioma. Avoid incision biopsy and perform complete excision in cases of orbital rhabdomyosarcoma. Superior orbital mass with bone destruction in a child, think of LCH and consider injecting intralesional steroids. Thank you everyone for patient listening.
ANASUA, thanks. That was really, really good, and progressively how a patient would come into the OPD and how we can break it down, and especially the last 2 slides actually summarize the whole thing, and you can